This is a live recording from Radiopedia.org's 2015 Emergency Radiology course in Melbourne, Australia, featuring Dr. Andrew Dixon and Dr. Frank Gaylard. For more information about Radiopedia courses, visit radiopedia.org/courses.
I just want to reiterate this point about, I've just tweeted, had a few comments back about the terminology and fracture description. It's a bit of a bugbear of mine in ED. When I'm on the flight deck and I hear registrars saying, oh, it's really bent, it's a mess, oh, it's really out of line, and you know, if you were the checkout chick at Coles or the local bus driver at the front of the hospital and you took them that x-ray, that's what they'd say. Please use medical and radiologic terminology. You don't see Andrew and Frank doing reports that say, oh, it's really bent, it's munted, you know, that's what I hear people say. So get on that post on ED exam, I've tweeted the link, and please use proper fracture description terminology. Thanks.
Thank you. I do occasionally use the term munted, but very, very selectively and appropriately as well. For the people who are coming down to accept their prize, I'm gonna up the level a little bit. You need to do a little bit of interaction with me when you come down. Otherwise, you're not getting your bowl of wine. Right. So lower limb, we're going to start with again, proximally and work our way distally. With the hips, here's just a normal anatomy of the hips. I want you to note the very smooth arc of that superior aspect of the femoral neck, okay? The smooth arc of that inferior aspect of the neck. And you can see these subtle trabecular lines heading down, so there's stress lines that help you bear the weight through that area, okay? These are all running nice and parallel to each other. The other thing to note on the lateral image is the same kind of thing. That femoral neck has a very, very nice curve to it. The head sits very much centred within the neck, so the neck's going from here across to here. The head sitting very centred within that neck, okay? With proximal femoral fractures or femoral neck fractures, femoral head fractures, the description in terms of the location, there's some words you need to know. If it goes through the head or the capitis, you know, it's called a capital fracture. Very rare to have one going through that kind of level. You often get these subcapital fractures, so at the base of the head, and then a transcervical or basicervical fracture, which is just down at the very distal margin of the neck. And then you get these proximal femoral fractures through the intertrochanteric region, so it's between the greater trochanter here and the lesser trochanter. And then if it's not involving the trochanters and it's below that, then we call that a subtrochanteric fracture. The important thing is it intracapsular or extracapsular? Same with the scaphoid. This is a case of, are they going to develop avascular necrosis or not? Okay. The capsule for the hip joint capsule inserts right down here, basically where that shading is. That's where the hip joint capsule is going to insert. All the vessels come through at that level and fire up to supply the head. Okay. So if you've got a fracture, any of these ones, subcapital fracture, probably a transcervical fracture or a lot of transcervical fractures, they're at risk of developing AVN. You'd call that an intracapsular fracture. These ones, extracapsular, no risk of AVN. Okay. Then there's the Garden classification for these. Again, trying to predict risk of avascular necrosis and whether they need to have a surgical replacement of the hip or not. Okay. It's all to do with how displaced the fracture is. If it's more displaced, obviously there's more likely that those blood vessels are going to be torn and you're going to develop avascular necrosis. If it's minimally displaced, non-displaced fracture through the subcapital neck of femur, all right, often they won't develop AVN. They can be treated with a dynamic hip screw rather than a complete replacement of the femoral head.
I've got a little saying for that. So an ortho-reg taught me once, 1 and 2 get a screw, 3 and 4 get a Moores. It's a way to just keep that in mind, that, you know, minor displacement, they can screw it back together, it'll probably heal and the head won't avascular necrose, but if it's really displaced, they take it off and do a hip replacement.
So here's a patient who's fallen down, pain in the hip. The fractures can be very, very subtle. You can see this lucent line through here. How does that project? Pretty subtle on the screen for you. All right. And you might see a little bit of disruption of the cortex up here as well. On the lateral projection, again, you're seeing that subtle lucent line. Again, this curve that should be a nice smooth curve is a little bit disrupted here, okay, at the posterior aspect of the neck. So that's a basicervical fracture through the femoral neck. This is probably intracapsular, this one, okay, but it's minimally displaced or non-displaced, so they're going to treat it with a dynamic hip screw. There's the dynamic hip screw. You can see by the time they've done that repair, the fracture line becomes a little bit clearer to see. That's the important thing to recognise. See that? The head, the neck comes up, and where it joins onto the head, you can see there's a little bit of impaction, sclerosis here, and the cortex, there's a little jump in the cortex. That's the subtle findings you're looking for a fracture. Here's another patient, left-sided, hip pain. You can see you're coming up the femoral neck here, and instead of it continuing along and then evolving into the head, you can see it comes along here, then you jump back to here, and then there's the head, and you can see this sclerotic line going through here, some overlap of the head over the neck. Okay. Again, this line disrupted, comes along here, then there's a little angulation in it. If you look on the lateral view, it can be pretty subtle, nice curve here at the front, following it along, probably a little step, and the femoral head is just a little bit, see how the neck is here? The whole head is just a little bit posteriorly located compared to where you'd like it, but quite subtle. On the CT, you can see there's actually quite an impacted. You can see that nice correlation to what we were seeing on the plain film coming along, and then that cortical step coming along here, bone, okay? So significantly impacted fracture of the femoral neck, intracapsular. This is an MRI of a patient who's got a stress fracture of the femoral neck. This is the classic location. It's at the inner aspect, the medial aspect of the neck. MRI is really good for showing you the marrow edema around the fracture and then low signal of the fracture line itself. But what I wanted to use this for is to kind of show you where the capsule inserts. This is the capsule coming right down to about here. This is the capsule attaching right over here. Okay? If you look on the axial images, see the joint of fusion continues all the way down to here. Okay? So you've got a huge amount of neck, okay, for the capsule. Remember, all the blood vessels have to be coming through here. Same on the posterior aspect, joint of fusion coming all the way along here, capsule inserting down here. All right? So just remember that the blood supply to the femoral head comes from way down at the base of the neck. And stress fracture in a runner, classically on that inner aspect, medial aspect. And I think this also just emphasises the importance of if you've got a patient who you suspect has a femoral neck fracture, can't see it on an X-ray, MRI is a great test. You're going to see very florid edema around the fracture and know that there's a significant injury there and be able to manage it appropriately. So MRI, very useful for suspected femoral neck. Again, we can have the debate about the bone scan. Obviously, you're going to see a lot of other injuries around the proximal femur with your MRI. You're going to be able to assess the gluteal tendons, hamstring origin, all these other things, the labrum. So MRI would be a preferred test. But if you just want to know if there's a fracture or not, a bone scan will also give you the answer. Here's a significantly displaced fracture, intertrochanteric, so the fracture's going through the intertrochanteric region. It's avulsed off the lesser trochanter here. The lesser trochanter is where the iliopsoas tendon attaches. So often when you fracture through the intertrochanteric region, that tendon is so strong that it tends to pull that lesser trochanter off, and it can move, it can stay close to its normal position or come up proximally. Okay, so that's not an uncommon thing. The point with this one is that the capsule is probably going to be preserved. This is at very low risk of developing AVN. They don't need to go and replace the femoral head. When we spoke about the clavicle earlier, we spoke about how it's an important site for metastases, myeloma, proximal femur, proximal humerus as well to a lesser degree, but proximal femur is another spot where it's worth having in the back of your head. You know, if they're fracturing here, is there an underlying lesion? This patient had a metastasis. You can see that permeative appearance to the bone, erosion of the cortex, okay, endosteal scalloping. See the lesion there, nice transverse fracture. Pathological fractures are often transverse as well. This is another form of pathological fracture. This is an elderly patient who has obviously had a fracture on the other side. They've got an intramedullary rod So they've had a fracture over this shaft in the past, and now they're presenting with a fracture of this shaft. The thing to note in this patient is that the cortex, for an elderly patient, the cortex is really, really thick, okay? And you can see how the cortex actually gets thicker right here, right where the fractures occurred, okay? So that means there's been abnormal stress through that bone for a long period of time. It's been laying down new periosteal bone, okay? So this is a stress type fracture of the femoral shaft. Now, why would an elderly patient be getting a stress fracture? It seems a little bit unusual. Usually we see them in young athletes running around too much. The answer is that this is a complication of bisphosphonate therapy. If you've been on bisphosphonates, and usually you have to be on them for a long time, 5, 10 years before you get this complication, you get this abnormal cortical thickening of the femoral shafts predisposed to getting pathological transverse fractures like this one, okay? So bisphosphonates trying to prevent a femoral neck fracture, often 5 to 10 years down the track, will cause a femoral shaft fracture. Okay, quiz case. 14-year-old injured while playing soccer. Where do you think he hurts? Diagnosis. Garth, are you here, Garth? Yeah, come down. There was one of our people who were watching online who said, as much paediatric emergency radiology as you can. So I've kept this little bit in, mainly for him. Come along, Garth, you're going to have to talk to me. Oh, no. Can you remember completing the quiz and getting this one right?
Yes.
So stand in front of the mic and just point out.
So we've got a avulsion fracture of the ischial tuberosity here.
Correct.
It's a classic fracture in kids, soccer kids especially.
It is almost always 14-year-old boy playing soccer for these ones. Or so get yourself a bottle of wine or some food. Thanks, Gar. The important thing to note here is there's lots of apophyses around the pelvis and proximal femur in kids where tendons are going to be inserting, okay? There's a greater tuberosity here where the gluteal tendons are coming down to insert. There's a lesser trochanter, I should be saying. Lesser trochanter here where the iliopsoas tendon is going to come down. You got a little bump here where the rectus femoris is going to have its origin. You've got a spine, anterior superior iliac spine here where tensor fascia lata and sartorius are going to have their origin. You've also got the abdominal muscles coming off the iliac crests up here. So plenty of paces. And of course, the hamstring origin coming off the ischial tuberosity. You've got lots of places where kids can pull off little bits of bone from those apophyses. The tendons in kids are stronger than the apophysis, the cartilage sitting at the apophysis, so they're going to pull them off. The important thing is pelvic radiograph, you've got perfect symmetry, so you can always spot which side is different to the other. That's what your go-to thing is. So this one, you can see, can you see that very fine lucent line there? That's the cartilage associated with that apophysis as it's starting to ossify next to it. On this side, that's just separated away from the bone, okay? I'm going to take you on a little tour of all of them here. Here you go, little separation of bone just above the acetabulum, that's the rectus femoris origin, or AIIS, avulsion. Here's another one on the other side. This is above the AIIS. This is the ASIS, okay, sartorius, tensor fascia lata, bone pulled off. Here's the lesser trochanter pulled off by iliopsoas. All right, iliac crests. Have a look at this iliac crest on this side. Nice thin line of cartilage with the ossifying bone outside that. On this side, again, nice thin line with ossifying bone. Then you've got this big line through it and then widening of where the cartilage should be. So that's an avulsion of the iliac crest. Now that person who asked online about having lots of paediatrics, that's it, we're done. Oh no, one more case for you, one more case. I think Jeremy covered this in the bonus video on paediatrics, the slipped upper femoral epiphysis. So again, we're talking about the same age group as those avulsion apophyseal injuries. This is the normal appearance of the hip in a 14-year-old. You can see that if you follow a line along the upper aspect of that femoral neck, it's called the line of Klein. If you draw a straight line, it intersects through a portion of the epiphysis, so the head of the femur. Okay, so the straight line there is going to intersect through. On the other side, if you do the same thing, straight line, it's barely going to touch it and may just hit the edge of it. This is a sign that this epiphysis has slipped medially relative to that femoral neck. There's also subtle widening of the physis itself, so the actual lucency is slightly wider on that side. If you have a look at the frog leg lateral view, this is important. Very, very subtle slips you're not going to see on that AP projection. You need to go on to have a lateral view. Again, you can see just that very subtle, as I said earlier, you've got the neck. You want to see the ball sitting very, very nicely in the centre of that neck. This one's slipping back, physis is widened. See this side, very, very small physis, little bit of growth plate there, wider, because you get a bit of resorption in the metaphysis of the bone that's being laid down, or disruption to ossification occurring there. These get pinned. There's a classification system for these that Frank's drawn a picture of. Widening of the physis, displacement. Grade 1 is if it's a mild slip is if it's 1/3, moderate slip if it comes across into the middle third, and a severe slip if it goes across even further. That's a picture of the line of Klein, nicely intersecting the epiphysis on this side, not intersecting the epiphysis on that side. Here's another one really grossly slipped. No prizes for detecting that injury. The important point here is, though, that the surgeon's going to go and repair that to stop it from slipping, because otherwise you're going to have a deformed femoral neck, going to develop osteoarthritis. But patients with slipped upper femoral epiphysis on one side are at very high risk of having the same happen on the other side, and so depending on surgical preference, they will often go and prophylactically put a pin in the other side, even if there's no signs of a slip there at all. Okay, so worth being aware of that. Let's move on to the knee. This is a normal lateral knee radiograph. Like with the elbow, the key to the knee is really looking for an effusion to try and detect whether there's any pathology going on in the knee. Fat is your friend in X-rays, it's your friend in CT. Okay, this is Hoffer's fat pad here, sitting deep to the patellar tendon. Okay, nice black fat sitting in this area. You can see exactly the thickness of that patellar tendon, and then a little bit of subcutaneous fat next to it there. Okay, if you come across into that suprapatellar region, again you've got fat from the back of the femoral, from the front aspect of that distal femur. You've got low density of fat coming all the way forward to the quadriceps tendon, which is here. Okay. If you get a joint effusion, you're going to see some fluid density, so the more dense, like the tendon or the muscle, filling this space here. You're also going to see that patella getting pushed forward by the joint effusion. On the frontal projection, I want you to be looking for tracing the actual condyles, looking for any articular steps, tracing the tibial plateau and the spines, making sure nothing's displaced. Looking at the edges here for any avulsion injuries. There's very small fractures around the knee that can be very significant. So having a good look at those areas when you're assessing a knee. The top of the fibula, this little bit of bone here out the lateral aspect of the tibial plateau. They're check areas on your AP film. Patella is another thing to look at on your AP film. Make sure it's nicely centered and all intact. This is just to correlate with that plain film, what you see on MRI. This bit of fat here, deep to the quadriceps tendon, is the quadriceps fat pad. In front of the distal femur, you have more fat, okay, so another fat pad here. And then the joint, this is the joint here, this is the joint space. That's the capsule coming up and reflecting on itself in the suprapatellar pouch. There's no fluid in it. You can see a tiny bit of fluid down here. There's barely any fluid in this patient. So that's your normal, no knee joint effusion. But I think it can show you where you're going to be looking on your plain film for a joint effusion. You're going to be seeing this fat at the back effaced. You're going to be seeing that quadriceps fat pad being effaced or squashed forwards. And you're going to see that patella getting a tilt and coming away from the distal femur. Okay. Don't think we'll do any of the other anatomy. ACL here, PCL, menisci. Obviously MRI, very, very good for assessing those internal structures of the knee. Okay, but from an emergency radiology point of view, it's probably better to recognise some of the plain film findings and to know when to refer for an MRI. Or come back to an MRI knee course that I might teach in the future. Okay, so here's an example of a knee joint effusion. So looking up here, quadriceps tendon, okay? Quadriceps fat pad, that triangular thing, looks exactly like we saw on the MRI. Fat just in front of the femur, exactly what we saw on the MRI, okay? But now you've got this soft tissue density, so similar to muscle or fluid density sitting within that suprapatellar pouch. That's a knee joint effusion. Okay. Here's a patient who's had a twisting injury to the knee. On the AP film, we're tracing the condyles, looks nice and intact. We're tracing the tibial plateau. I can't see any step there, looks good. We're looking for little avulsion fractures out the side here. We're looking at the fibular head, make sure that's intact. On the lateral image, we've got our quadriceps fat pad. Again, that little triangle of fat there, quadriceps tendon, a little bit of fat in front of the femur, and then you've got all this fluid density sitting here. You can see how the patella's tilted forward just a little bit from that fluid as well. So a knee joint effusion in this patient. Here's another one who has presented after falling on the knee, and clinically they say gross knee joint effusion, okay? And we're going to use our findings. We're seeing that there's fairly uniform density throughout this region here. It's a bit hard to define the tendons and the fat, but it doesn't look like you've got an obvious joint effusion in here. It's not tilting the patella forward at all. But what you've got is, if we go back to the previous case, or even further forward, that fat in front of the patella and in front of the patella and the patella tendon is very, very thin, okay? If we go forward to our case here, look how thick these tissues are in front of the patella. Okay, normally the fat should look like this, nice and dark. You should be able to see the muscle. Here it's all very, very soft tissue, fluid density. So they've got a pre-patellar hematoma, okay? They've not actually got a joint effusion. Clinically, some people can get confused. I think as a radiologist or as someone interpreting this, it's actually important to put that in your report, okay? You say, because we'll often report this as there's no knee joint effusion, no fracture or malalignment, but I think it's worth saying there is significant prepatellar soft tissue swelling consistent with prepatellar hematoma in this setting, okay? If it was not in a different setting, you might say prepatellar bursitis, okay? Important to mention that because otherwise the clinician's going, oh, why is he so swollen if there's no joint effusion? Helps them understand different spaces. All right, 40-year-old male, unable to walk following a fall and twisting injury, looking for a fracture. All right, so AP film, let's do our little routine. Following those condyles, no step, following those plateau, no step, all looks pretty good. No avulsion fractures that we can spot around here. The patella looks like it's all nice and intact. On the horizontal beam lateral image, often they come across looking like this rather than like that, so I'll use that orientation. So this is an X-ray, and all these X-rays in a suspected knee injury, the lateral image should be performed as a horizontal beam shoot through. So basically you're using gravity, this is a down and this is up. And what you're looking for is, in this case, you've got a joint effusion, nice rounded bit of stuff sitting up here, tilt of the patella forward. What you're looking for is this perfectly horizontal line, which we saw in the shoulder, a lipohemarthrosis. I think it does it project all right, but that is the quadriceps fat pad. See that little triangle there, slightly different density? Quadriceps fat pad, patella tendon, and then this little extra bit of fat here with a perfectly straight line. So a lipohemarthrosis, like we saw in the shoulder, implies that there must be a fracture that's intra-articular, allowing some of the marrow fat to leak out into the joint, okay? We use it to our advantage here because that means this patient must have an intra-articular fracture of their knee, but we couldn't spot it on our EP projection. We can follow our condyles around here on the lateral projection. We're still struggling to spot a fracture. You can see Hoffer's fat pad here, nice low density anteriorly, but it's looking a little bit fluid density in the deeper portions of that fat pad. So we're suspecting there's been an injury within the knee. We go on and we get a CT. and we confirm that there is indeed an intra-articular fracture that we weren't spotting on our plain film. It's very common for these lateral tibial plateau fractures to be occult on your X-ray. This could develop into an unstable fragment, if the patient isn't managed appropriately. Okay, so, and then correlation with that lipohemarthrosis, quadriceps fat pad here, that little bit, that's the lipohemarthrosis forming a perfectly straight line. On the axial images, again here, perfectly straight line, fat in front, blood sitting behind it. The key is there, recognising the lipohemarthrosis. No one's going to spot the fracture, but everyone should spot that lipohemarthrosis and know there's going to be a fracture and request the CT. Oh, this image hasn't loaded. That was just a nice example of a lipohemarthrosis on soft tissue windows, just to really emphasise what that looks like. Okay, this is a poll question, so get out your phones. We're going to try and spot as many injuries as we can on this patient. So we've got lots of options: lipohemarthrosis, joint effusion, lateral collateral ligament avulsion. I've been talking about little avulsion fractures, so surely there's going to be one here. Lateral collateral ligament avulsion, second fracture, ACL avulsion. Here's the images. I'm just going to zoom around a little bit and give you a chance to look at things. All right, let's go back and see, lots of responses. Here we go. So we'll start with the most frequently. So joint effusion, but there's a little bit of a mix. There's some people saying there's a joint effusion there, other people saying there's a lipohemarthrosis. Majority just saying there's a joint effusion, no lipohemarthrosis. I would agree with there's a joint effusion. There's a huge bit of soft tissue fluid density sitting up here in the patellar pouch, pushing that patella forward, okay, but I can't see a perfectly straight fat fluid level sitting in there, okay, so no lipohemarthrosis, but there is a joint effusion. Lots of people selecting a lateral collateral ligament avulsion, not many people knowing what a second fracture is, and ACL avulsion, a few people seeing that. So let's have a look. Now the lateral collateral ligament is also known as the fibular collateral ligament because it attaches to the fibula. It doesn't attach to the tibia. So this bit of bone here, which you've all probably spotted as being avulsed, has nothing to do with the fibular collateral ligament. The lateral collateral ligament comes from here, goes down and attaches onto the head of the fibula, okay? This is something else that's avulsed here. This is just a capsular attachment, or there's some debate about whether it's an actual ligament, but there's a capsular attachment here at the anterolateral capsule of the knee joint. Pulls off a bone, it's called a second fracture. Now why is it important? Because they're almost always associated with an anterior cruciate ligament tear, complete tear. Okay, they're also associated with meniscal injuries. So if you don't spot this little fracture, then you're going to potentially miss, as soon as you spot that, you know he needs an MRI. Okay, so miss that fracture and you might miss an important ACL injury. There's also little bits of bone sitting in here in the spines are not quite intact, so there is an ACL avulsion fracture there as well. And was there any other options that we had? That was it. Okay, so the answer is joint effusion, second fracture, and ACL avulsion. So this patient did go on and had an MRI and had a complete rupture of their anterior cruciate ligament. Here's another patient, just to tell you that they look the same every time. Second fracture, always this tiny little bit of bone avulsed from that lateral aspect of the tibial plateau. Okay. Again, in this case, the patient has a joint effusion without a lipohemarthrosis, telling you that that's not an intra-articular portion of the joint. Okay, another view just showing you that nice little avulsion fracture. You can actually get a reverse second fracture on the other side, a little avulsion of the capsule there. That's often related to a posterior cruciate ligament tear. The next little avulsion fracture that's important to know about is this tiny little bit of bone here. Can you see that? Pulled off the top of the fibula. It's really hard to see often. Okay, that's why I was talking about looking for that area specifically. Hard to see on the lateral as well. This is where the posterolateral corner structures all come down and insert on the knee. It's not just the fibular-collateral ligament. In fact, that lateral collateral ligament is very, very thin, cord-like. The main thing that inserts down here is the biceps femoris tendon and the arcuate ligament complex, which is a strong stabiliser at the posterolateral aspect of the knee. If you've avulsed bone there, you've obviously injured that area. It's another sign that they've had a twisting injury and they'll have an ACL tear or most certainly meniscal injuries. Okay, so they need to have an MRI. That's called an arcuate sign, if you see that. This patient does have a lipohemarthrosis. Nice straight line sitting up here. I just want to show you, again, MRI is not the focus of this talk, but here is a patient who's got a complete rupture of their ACL. PCL, this one at the back, like a hockey stick, looks nice and intact. ACL should be going along here, should look nice, tight, black thing. It's completely torn. And what I wanted to point out was, or is, this here is that tiny little bit of cortex, see that black line? That's a tiny little bit of bone that's been pulled off here. Okay, that's that capsule. That's that little avulsion fracture, that's the Sagon fracture. That's all you're going to see on the plain film from this patient, is that tiny little fracture. And yet the major injury has nothing to do with that. That doesn't really matter. It's all this other stuff that's going on. They've got significant tears of their menisci. They've got a complete tear of their anterior cruciate ligament. Look at the tears through this, through this meniscus here. You can also see in this case the reason why you might injure your posterolateral corner and pull off your, a little bit of bone from there. Again, look, a little bit of marrow edema. It hasn't actually pulled off, but this is the biceps tendency. There's been injury to that, and it's wanted to pull off a little bit of bone here. These are the posterolateral corner ligaments, the arcuate ligament complex. They're all hyperintense, partially torn. So this patient has got a posterolateral corner injury, but you can't see the little, there's no little fracture there. Okay, so spotting that Sagon fracture on the plain film, very important. If there's an injury at the posterolateral corner in a patient who needs an ACL repair, that often is important to recognise because they need to repair that posterolateral corner as well. Otherwise, they get graft dysfunction from their ACL repair. All right. But from your point of view, looking for those tiny little avulsion fractures, small but very important. Trauma in a young adult male. Go through our approach here again. We've got nice smooth-looking condyles, smooth-looking tibial plateau and spines. Can't see any little avulsions of bone anywhere. But what we do notice with the patella, I'll just zoom out a little bit. We do notice with the patella is that you've got this defect or bit of bone fragment at the superolateral aspect of the patella. Okay, nice, looks like a fracture, doesn't it? But it's important to recognise this as an anatomical variant. This is a bipartite patella, not to be confused with a fracture. The key is the location, always superolateral, always looks the same, so if you can imprint that into your head, you'll be able to recognise it. But the other key is, if you've got a patella fracture, you should have a lot of swelling out the front of your patella, which this patient doesn't have. You should have a joint effusion, which this patient doesn't really have, okay? So, bipartite patella, don't confuse it for a patella fracture. We're not going to look at patella fractures because they're relatively easy, but we are going to talk about patella dislocation. Patella always dislocates laterally like this. It's very rare that we do a plain film of it while it's dislocated because most people push it back in, okay, but that's what it looks like on plain film. Again, this is an area where it's important to think about MRI. If you have a patient who presents with an injury to their knee, often they don't know they dislocated because it just transiently comes out and then goes back in. So if you have someone who you think, oh, they've had an injury to their knee, you do an x-ray, they've got a bit of a joint effusion, but I can't see a fracture. One thing to think about is, have they had a transient patellar dislocation? And if so, do I need to look into that further with an MRI? Okay. On MRI, you're going to see this classic, what we call kissing contusions. Okay. Marrow edema here in the medial aspect of the patella, corresponding with this contusion, marrow edema on the lateral femoral condyle. Okay. So this patella came across, clunked onto the lateral femoral condyle. Now the reason why we do the MRI is not to spot that marrow edema. That does confirm that they've obviously had a dislocation. But what we want to do is assess for any cartilaginous injury. You can see how this grey area from here to here is the cartilage, comes across and kind of stops there. All right, so the cartilage has been involved at that point. What we also want to assess is the medial patellar retinaculum, or the medial patellofemoral ligament. So this structure that stabilises the patella, it comes out and inserts out the side here. It should be nice and black, thin line like this. It should continue along and insert just in front of the medial collateral ligament here. In this case, it's very hyper intense and irregular in that area. So there's been a high grade tear of that medial patellar retinaculum at the femoral attachment. That's associated with ongoing instability. They're going to keep, once you dislocate once, you're going to keep dislocating. It's also good, the MRI, to look for underlying risk factors for patellar dislocation. You know, you can see this patient has a very shallow trochlear groove. It should be a nice deep groove. And obviously the patella is also subluxed out laterally. But the important thing from an emergency radiology point of view is patellar dislocations, often the patient doesn't know that they had a dislocation. They just think they had an injury to their knee, okay? So important to always think about, could this have been a transient patellar dislocation? And then always you need to do an MRI to look for that osteochondral injury. If there's a bit of bone and a bit of cartilage that's come off, you're only going to see that with the MRI, okay? Quiz case, 40-year-old, unable to weight bear after an inversion injury, question mark, abnormality. We're moving down to the ankle now. And our winner for this one is Jalin. Is that how I pronounce it? Would you like to come down? Yeah. Now, I must say that this question, there were not a lot of right answers for this one. And perhaps it's because the images weren't zoomed in very well and people couldn't really zoom in on their iPhone or whatever they were using and couldn't spot the injury. But this is how the images are presented when the patient comes in. They're often a very wide field to include lots of areas. Do you want to point out the injury?
I don't remember where I found it.
You don't remember it?
I've got to try.
There's a bottle of wine writing.
There's a little tip right there.
Exactly. You can get yourself a prize. So this... Having a systematic approach to the ankle is important, and one of the check areas is the talar dome, okay? This bit of bone that goes around here, and looking for any subtle fracture at that site. So you can see here that little bit of bone that's come off. This is important because there's a fracture, but over the top of that there's cartilage, okay? So there's a big fracture going through the cartilage that could be unstable, displace away. They're going to get degenerative disease within their ankle joint, and it's very hard to spot, okay? Everything else in this ankle looks pretty normal. They may have a bit of an ankle joint effusion. You can see that the fat is a bit effaced out the front here. We'll describe that again in a moment. There's an arrow on that little bone fragment. So lateral corner of the talar dome, very important injury to recognise. Any talar dome injury, important to recognise. I wanted to use this patient also to just to run through some of the normal alignment that you should be looking at on an ankle radiograph. This, the distal tibiofibular joint, or the tibiofibular syndesmosis, is very important to the stability of the ankle. And you want to see a nice overlap between this tibia here, all right, and the fibula. You want to see at least 6 millimetres of overlap on your AP film, all right. On your mortise view, which is an oblique view, you still want to see a little bit of overlap, at least 1 millimetre of overlap on your mortise view, okay? The second line, or the second measurement I want you to take note of is this line here. So if you go from, see that kind of sclerotic line there, across to the fibula, that's actually the joint. That's the tibiofibular joint, okay? Again, 6 millimetres is the number here, but instead of talking about big number, we want it to be a small number, okay? We want those two to be close to each other. So they need to be less than 6 millimetres, okay? If that line gets too wide, obviously you're going to get less overlap, so you're going to get less overlap, a bigger tibiofibular clear space. That's a sign of a tibiofibular syndesmotic injury, which is very important to fix. Okay. The third one is the medial clear space. You can forget about the lateral clear space. This always looks funny. Don't worry about that. So these three are the things to look for. The overlap sign, the clear space here, tibiofibular clear space, and the medial clear space. This should be less than 5 millimetres. That's the distance between this line here, right, and where it's going to articulate with, which is this line coming down here, all right? This is not a great example of it. You can usually see it a bit more easily than that. So there's some of the things to think about when you're assessing the alignment of the ankle joint. Here's a nice example of an ankle joint effusion. Again, we're talking about the the fat. You should normally have fat sitting out the front of your ankle joint. Here's the nice fat here with some tendons coming down the front. And you can see here this nice rounded ball of fluid poking out the front of the joint. That's an ankle joint effusion. At the back, I don't think you can assess ankle joint effusions very well at the back. You often have muscles and you often have a little bit of physiological fluid coming out the back of your ankle anyway, okay? But this probably does have a bit more than you'd expect. So that's your ankle joint effusion. Not as important to recognise ankle joint effusion as it is in the knee or in the elbow, because most ankle joint effusions are just due to a sprain of the ankle and there's no actual, fracture. So it's not as important to look for as the others. The alignment and the talar dome, much more important to look for. As you get older, almost everyone starts to develop these little bits of bone around the medial malleolus and sometimes around the tip of the lateral malleolus, okay? The important thing to recognise is this bit of bone here is well corticated, and by that we mean that it has a cortical margin. See how the margin of this bone is slightly more dense than the medullary cavity, okay? This bit of bone here has a nice cortical margin to it the whole way around. So that's just an accessory ossicle, os tibiale or something. Or it's the result of an old avulsion fracture of the deltoid ligament from there and is of no significance, okay? You develop a little bit of bone to heal that avulsion, okay? Very, very common. The key thing to look for is there any disruption of cortex? Are you seeing a little bit of bone that has a marrow exposed on it, or does it have cortex sitting all the way around it? You'll hear us use the term in our reports, well corticated. There is a well corticated bone fragment. We're saying that's old, it's been there for a long time, it's an accessory ossicle, or it's an old avulsion injury. We're not interested in it. Okay. A basketball inversion injury, ankle swelling. I think assessing, as we've seen elsewhere, assessing for soft tissue swelling is an important thing on all of the joints. You can see the soft tissue swelling over this lateral malleolus is quite marked. There's no swelling over on the medial side here, okay? So straight away you know the injury's on the lateral side and you want to look for a fracture. Here you can see a transverse fracture through the distal fibula. You probably all know about the Weber classification for ankle fractures. It's all about the level of the ankle joint or the talar dome. If it's below that level, then that's a Weber A fracture. That's stable. There's not going to be any injury to the distal tibiofibular syndesmosis or the anterior tibiofibular ligament. Okay, they're going to be intact. You can see here you've got nice overlap sign. It's a bit hard to assess that tibiofibular clear space. You've got a nice medial clear space. So there's no instability of this ankle. Nice talar dome, all intact. So that's a Weber A fracture of the distal fibula, soft tissue swelling over the top, stable injury. I think a lot of people forget to look at the lateral image to assess the distal fibula because things start to overlap, and as soon as things overlap, you ignore it. Okay, but you can see the fibula coming down here. You can see the distal margin of it. And then you can see this, it doesn't project fantastically on the screen there, but you can see a little fracture going through it. So I would advise you, if you're looking at the AP and you're not sure that there's a fracture there, there's some soft tissue swelling next to it, have a look at the lateral, also have a look at the mortise view, and you may be able to spot that fracture a little bit more clearly. This little cortical step here is the key, and then the lucent line going through it. Don't forget the lateral. Another diagram from Frank in 2009. He was prolific. Again, just emphasising Weber A is below the level of the talar dome. Weber B, it's the inner margin, it's the medial margin of the fracture that you're talking about. Often the lateral margin is going to ascend up the fibula quite a way. Okay? It's this inner margin, that's where you assess whether it's at the level of the talar dome. If it is, that's a Weber B fracture. They can be unstable, might be stable, okay? Go on and look for your tibiofibular clear space, look for your overlap sign, look for your medial clear space to see whether there's a significant injury. Often they might be associated with a medial malleolus fracture, in which case they're clearly going to be unstable, all right? The final one is the Weber C fracture. If it's well above the level of the talar dome, that's a Weber C fracture. That always injures the distal tibiofibular syndesmosis. If the distal tibiofibular syndesmosis is disrupted, it needs to be repaired. They all need to go to the orthopaedic surgeon, okay? Again, very often associated with a medial malleolus fracture or fractures of these deltoid ligaments over here, deep ligaments, superficial ligaments. Here's a few examples. All right, so this patient, we're going to look at the medial aspect of the fracture, okay? It's sitting at the level of talar dome, so we're calling this a Weber B fracture. It looks displaced. Let's have a look at the AP film. Here's the AP film. What do you think of this overlap here? 6 millimetres? It's probably a bit less. It's a bit borderline, isn't it? This tibiofibular clear space, it's a little bit more than 5 millimetres. So we're thinking there's a bit of an injury to the tibiofibular syndesmosis. Here's the medial clear space here. Again, looks like it's a little bit more. It should be very similar to this distance here. Looks like it's a little bit more, and there's a transverse fracture through that medial malleolus. So this is a Weber B fracture. We're going to take it to the next level, and we're going to tell him this is a Weber B fracture with an associated medial malleolus fracture, and there are signs of disruption of the tibiofibular syndesmosis. Okay, this is going to need surgical repair. In my report, I don't usually say it needs surgery. I say this is an unstable fracture. Okay, that means you guys need to fix it. And there they have fixed it, but did they listen to our report? We said tibiofibular syndesmosis is disrupted. They've fixed the fibula, they've fixed that medial malleolus, but they haven't stuck a screw through the distal tibiofibular syndesmosis. And you can see here, this is a mortise view. There's no overlap between the distal tibia and the fibula. On the AP view, there's no overlap at all. Okay, this is really wide. So they need to go back and fix that. So if they had have looked at the plain film in more detail initially, they would have detected that injury. And the final one is the Weber C fracture. Up here, any fracture that's up this high, it's always going to be unstable. There's no overlap sign here. There's widening of that tibiofibular clear space. The medial clear space is from here to here, way too wide. Associated fracture, medial malleolus. Also a posterior fracture, posterior malleolus fracture. Here's another one, which is another radiology registrar exam kind of case, this one.
Can I make one point just about the posterior malleolus? Because that's a point that a lot of people don't seem to know about the terminology. So your uni, bio, trimalleolar, if you've heard of trimalleolar, you've got to look on the lateral and see the posterior. And can you just go back to that picture? And if you don't see any other injuries, but you just see a posterior malleolar fracture, X-ray the rest of the leg, because sometimes they'll have a proximal fracture. Because remember that system, the tibia and fibula is a ring structure. So if you break one bit, it often breaks in another. So or examine clinically at least to see if they've got pain higher up.
Well, we were just going to talk about the ring, because this is an example of that. You're looking at this and you're seeing that there's widening of the. So if I go into the AP, widening of that medial clear space. The distal tibiofibular syndesmosis looks all right, nice overlap sign, nice clear space here, but clearly that tibia looks like it's moved out a little bit, so there's an unstable injury, but there's no fracture. And in this case where you can see one bit that's torn, but you can't see the other part of the ring that's been disrupted, you need to look proximally for it. Okay, so this patient, when you look at their knee radiograph, you can see a proximal fibular fracture. That pattern is called a Maisonneuve. I'm probably pronouncing it wrong, and there's lots of people watching this in France, so I apologise, but that's called a Maisonneuve. And that's a classic for radiology registrar exams. They love that one because you need to suggest the next test, which is the knee radiograph.
And I really want to reiterate that point, because this is a common morbidity, mortality meeting X-ray that comes up, is people, when you get the sprained ankle in fast track now, everyone gets rushed in to see the patient. Can you just order an X-ray for this patient? Everyone just examines the ankle. When you examine an ankle, part of your ankle examination is palpate the proximal fibula. You'd be amazed the amount of times people go, actually that's a bit sore. X-ray the whole thing and you'll pick these proximal fractures. Don't just focus on the ankle.
Okay, a patient who rolled their ankle a day ago, can't wait there. We're moving on a little bit from the ankle. This patient has a calcaneal fracture. Very strange history, twisting their ankle. Usually it's jumping from a height onto your foot, okay? But the important thing here is that sometimes the fracture itself can be hard to spot, but there is some cortical disruption, trabecular disruption going through the calcaneal body here. The important thing is a measurement called Bowler's angle. To be honest, I never measure it myself, I just eyeball it, okay? But if you are going to measure it, and if you're inexperienced, you probably should be measuring it to look for a fracture of the calcaneum. You measure it along the top aspect of the calcaneal tuberosity here, or the calcaneal body, and then there's a little point up here. If you look at the one without the annotation, see that little margin there? Posterior aspect of the subtalar joint, there's a little bulge. So a line along here, and compare that to a line from this anterior process of the calcaneum, a line that goes along there and goes across that same point. So if you draw the angle between those two things, it should be at least 20 degrees up to 40 degrees. Okay, that's a normal bowler angle. If the angle is more than 40 degrees, I don't know, that's just awesome. So forget that. It's less than 20 degrees that you want to think about. Okay, so flattening of that ankle, the calcaneum has become impacted and has started to fall into itself.
So again, don't calculate bowler's angle, just get a CT. If you think if a fractured calcaneum crosses your mind, just scan them.
Yeah, if there's any clinical concern for a calcaneal fracture, get a CT. Okay, so pain at the fifth metatarsal base following a twisting injury. This is a good history. Twisting injury of the ankle and a metatarsal base tenderness is very, very common. Okay, so they go together. So this is a 10-year-old, and as we saw in the elbow with kids, you know, they all have these little growth plates, which makes it really difficult to interpret if you haven't looked at a lot, okay? And at the base of the fifth metatarsal, you have an apophysis. This is where the peroneus brevis tendon comes and inserts onto the base of the fifth metatarsal. It always forms this longitudinal line. That's the normal apophysis at the base of the fifth metatarsal, longitudinal. Fractures are always transverse. So in this patient, this is the normal apophysis, this is the fracture. So it's worth noting, because we have people where there's no fracture come to us all the time and say, oh, there's a fracture here. If it's longitudinal and they're a kid, then it's going to be the apophysis. Look for a transverse line. Frank, again, 2009, what a year. Here's a picture that he's drawn to just depict the different types of fractures at the base of the fifth metatarsal. There's three that you kind of need to know about. The first one we've just seen there, which is where it extends into the joint, and it's right at the tip of the fifth metatarsal base. That's an avulsion fracture, peroneus brevis pulling off the bone there. Twist your ankle, tendon pulls it off. If it's a little bit further along than that, then we call that a Jones fracture. Okay, you'll see an example in a second. If it's a little bit further along than that, then it's often a stress fracture, but you want to see other secondary signs to suggest that there's been stress there in the past. Okay, so worth knowing the different kind of spots. Os perineum is a little bit of bone here that's worth knowing about. There's also another little ossicle, I've forgotten its name, that sits here, vasaralium or something. Worth knowing about those because people can confuse those as fractures. Again, corticated margin equals an ossicle or an old injury, not acute. So here we go, forced inversion injury, fifth metatarsal pain. Here's the picture, transverse fracture coming into the joint here on the oblique radiograph, slightly displaced, coming into the joint. That's consistent with a peroneus brevis avulsion injury, the base of the fifth metatarsal. This one further along doesn't go into the joint, joints all preserved, so not an intra-articular fracture. Further along, this is a Jones fracture. There's no suggestion that there's underlying stress response in his bone, so it's not a stress fracture. All right. These ones, the Jones fractures, more so than the avulsion fractures, have a nasty habit of not uniting. Very, very common for these not to unite. So the surgeon may go in and stabilise this fracture. All right. So, and it's certainly worth getting serial follow-up films to look for non-union of these Jones fractures. The third one is the stress fracture, slightly further along the shaft. See how the cortex becomes thickened? Remember back to our woman who had the bisphosphonates, had a stress fracture. You could see the cortical thickening, the chronic remodelling of the periosteum there. Same thing here, it starts to bulge out, then you've got a fracture through the bone there. You'll see it on the oblique and on the lateral as well. See how the bone comes along and just gets a little bit thick right where the fracture is. Too much running, sudden pain, stress fracture, base of the fifth metatarsal. The more common place for your stress fractures is in the third and fourth metatarsals, distal shaft kind of area. This is what you'll see. You might not necessarily see the fracture, but you'll see periosteal new bone if the stress response has been going for long enough. You get this fluffy kind of bone. If it's fluffy like this, that means it's active. It's chronic, it's actively trying to heal the stress that's in the bone, the micro-fracturing. There's probably a subtle fracture going through this one. If you get a film later on, once they've rested, stopped running because they run too much, have a rest, you'll see that periosteal bone is still thickened. It's always going to be thickened, but it's nicely remodeled, very, very smooth. Okay, so that's a chronic, benign periosteal reaction there. That means that it's all healed up. So fluffy is the active periosteal reaction. All right, quiz case number 6. 25-year-old with foot pain after a fall. Is there an important injury? It'd be great if the answer was no, but of course the answer is going to be yes, and trying to find what it is. Here's our winner, Z Tan. Do you want to come down? I'm going to skip forward to the next case to talk about some of the normal anatomy of the foot. And the normal anatomy I want to point out is the tarsometatarsal articulation, which is also known as the Lisfranc joint. Okay, so the Lisfranc joint is the joint that comes along here, all right, and is the articulation between the tarsal bones, cuneiforms, and the cuboid and those metatarsal bases. Okay, this is the key alignment here. The alignment of that medial cuneiform, sorry, the lateral cuneiform there. So it might be the intermediate cuneiform, sorry, and the base of that second metatarsal. That should be a nice smooth line between those two. This is where the Lisfranc ligament goes across. Again, French people, it's probably Lefranc or something like that, but in Australia we say Lisfranc. And so that's the normal distance between the cuneiform here and the base of that second metatarsal. All right. That's the alignment we want to be looking for. And if we go back to the case here.
Sorry. There was a...
Speak up.
I think there was a Lisfranc space over there, and then, yeah, that's pretty much it.
Yeah, so excellent. You spotted it. That's the main thing. See that little bit of bone that's come off the base of that second metatarsal? Okay, and widening of that distance. If you follow this margin, there's a little bit of a step back to here. It's very subtle, but it's a very important injury. Take your prize. This is another case where the vast majority of people who looked at this got it wrong, missed the injury. Okay, and yet this is a very, very important injury to detect. Okay, so a little avulsion fracture where that Lisfranc ligament is going to insert. The thing about this joint, and the reason why it's called a Lisfranc ligament and Lisfranc joint, is because Lisfranc, during I think the Napoleonic Wars or something, Lisfranc was a surgeon. He was probably an obstetrician or something, because most of them were obstetricians back then. He was on the battlefield, and he worked out the fastest way to amputate the forefoot was to cut through that ligament there. If you cut through there, it just falls away. Okay, and it cut the time down from being a lot of sawing to being just dissect down there, cut that, and then you'll be able to get that joint dislocated and take off the forefoot. Okay, so that's how the origin came about. If you look at that's the normal orientation. Here's what happens when that joint dislocates. And that patient who's got the fracture there, the avulsion fracture of the ligament, they're at risk of this happening. It's going to be unstable. All those metatarsal bases are going to start sliding off to the side unless there's a surgical repair. Even if it doesn't slide all the way off, you're going to get altered mechanics, you're going to get degenerative disease of that midfoot. Okay, so Lisfranc fracture dislocation. And now it is morning tea time. I think we're about 5 or 10 minutes early, which is good. So we'll have half an hour for morning tea, and we'll be back here at 11 a.m.